started now. So my name's Neha. I'm Vice President of Leicester Radiology Society. Today we'll be doing a session on chest and cardiovascular imaging. These slides have been reviewed by consultant radiologist Dr. Kushal Joshi. We also have Abigail, who's President of Leicester Radiology Society, joined with us today, who will also be answering questions on the chat.
Hello.
Yep. And this session is also going to be recorded and will be put up onto YouTube, so it can be watched later on to review again. And I want this to be an interactive session, so there'll be interactive cases, and I just hope you guys can put some stuff down in the chat. And yeah, we'll go from there. So in terms of what we're going to cover today, we will be going through how to interpret chest x-rays, then we'll do 8 cases, and then summarize at the end. So in terms of when we are looking to interpret chest x-rays, we need to know what a normal chest x-ray looks like so that we then know what abnormal looks like. So this is a really good diagram from Geeky Medics that sort of highlights what normal anatomy on a chest x-ray looks like. So you can see the trachea that's highlighted in green, which then bifurcates into at the carina into the left and right main bronchus. You can see the borders of the heart, and then you can see the right hemidiaphragm and the left hemidiaphragm. The hemidiaphragm and the border of the lung then form your costophrenic angle, which will be very useful later on to know where that is, as it's useful in identifying certain pathologies. And then you've also got your aortic arch, your hilum, where you have the blood vessels and lymphatics that come out from that area as well. And then that is the left lung, that is the right lung. And then ribs, you've got your posterior ribs here, and then your anterior ribs coming out like this. So yeah, and then that's just a gastric bubble that you can sometimes see on chest x-rays as well. So that's what normal anatomy on a chest x-ray looks like. Oh, we've also got clavicle and then obviously the other bones as well. In terms of when we want to interpret a chest x-ray, there's certain steps that we can follow so that we don't miss anything when we're looking at a chest x-ray. So in OSCEs and things like this is a good sort of way to approach an x-ray when given one. So the first thing you want to do is confirm patient details. So patient's name, date of birth, NHS number, 3-point ID check. The video still shows slide titled agenda. Let me see. Is that for everyone else as well? Are the slides moving? No. Slides are moving. Okay, maybe try and rejoin. So maybe leave and rejoin or refresh the page. That might help if the slides aren't moving. Try that and see if that works. But I think I'll continue because it looks like it's moving for everyone else. Okay. So there's 2 mnemonics that we can use to interpret chest x-ray. You might have already heard them before. So one is called RIPE, and then the other one is ABCDE. So RIPE can be used to explain the chest x-ray. You can look at it first in terms of rotation. So in terms of rotation, you're looking at if the medial bit of the clavicle is equidistant to the spinous processes. And that should give you a good idea. In terms of the second point is inspiration. So you want to make sure that the chest x-ray is well inspirated. So you can see 5 to 6 anterior ribs. You can see the lung apices, both of the costophrenic angles that I mentioned before, and the lateral rib edges should also be seen in that image. And then projection. So knowing if it's PA versus AP. If the scapula are not projected within the chest, then it's PA. And just another point about PA and AP, which we'll see in the cases as well. But in AP chest X-rays, there's exaggeration of the heart. So the heart can look a bit bigger than normal. And this is because the X-ray source is further away from the heart than the film plate, which causes magnification of the heart. But we will also go through this again in another case later on. And then you also just want to look at exposure, so making sure that left hemidiaphragm is visible to the spine and the vertebrae behind the heart. So if it's overexposed, it will look too white and you won't be able to see that anatomy. And then A, B, C, D, E is sort of the main looking at the chest X-ray, looking for that pathology. So A, we want to look at airway. So those are things like the trachea, the carina, the bronchi, and hilar structures. And then B, breathing, we want to look at lungs and the pleura. Cardiac, that's looking at the heart size and borders. Diaphragm, that's just looking at those costophrenic angles and if it's flattened or not, or raised. And then E for everything else, so the mediastinal contours, bones, soft tissues, valves, pacemakers, any other extra things that you can see. So we're going to move on to the cases now. So the first case we have is a 65-year-old woman who presents to A&E with a 3-day history of fever, productive cough, and a pleuritic chest pain. We've been given some observations, so rest rate of 32, blood pressure of 110 by 65, heart rate of 96, and temp of 38.5. So at this point, what investigations would you guys like to do? Just put them in the chat, anything that you guys are thinking of. Any investigations, you guys, that come to mind? Bedside, yep, that's good. ECG, sputum, pot. I like that you've thought about bedside first. What sort of bloods would we be thinking of doing? Bloods, yep, that's great. Full blood count, CRP, blood cultures. And anything else that we'd want to do? BBG, yeah. Imaging, perfect, chest X-ray, yep. Those are the answers that I was looking for. So yeah, we've got that sputum culture, full blood count. Renal profile is good to do as well, just because if we start any medications, it's good to know what the renal function is. And also urea will be quite useful later on as well. So now we've got our chest X-ray. Can anyone tell me what the main finding that you can see on this chest X-ray? Just have a go describing as best as you can. So yeah. If you're not sure, then which side do you think? Do you think the left side has the finding? Do you see it more on the right? What looks different on this chest X-ray? Even if you don't know how to. Oh, okay. Patchy consolidation in the right lower and middle zones. Yep, that's definitely there. That's right. There's also some on the left, but it's not as much. But yeah, we've got that consolidation in the right, middle, and lower zones here. And we've also got a loss of that hemidiaphragm that we had, and that left middle zone consolidation, which fits into that clinical picture that we had earlier of pneumonia. So now, because she's presented to hospital, one of the things that we want to calculate is her CURB-65 score. I've given some values there. And if you guys want to have a go at calculating that CURB-65 score. She doesn't have any confusion. Any guesses? 2. Yep, spot on. So with the Curb65 score, it's basically a tool to predict mortality rates in people with pneumonia, and it's used when patients present to hospital. So I said that there was no confusion. The patient wasn't confused, so she doesn't score anything for that. For urea, her urea is 6, and the cutoff for that is 7. So if the urea is more than 7, then she would score a point, but because it's 6, she doesn't score a point here. Her respirate is 32, and the respirate cutoff is 30, so she scores a 0.1 for the respirate. And then her age is 65, so anyone aged 65 or more would also score 1 point. So her overall curb score would be 2. And because it's 2, that comes under a intermediate risk profile, which means that we would consider hospital admission for this patient and start her on some IV antibiotics. Just another general question to test you about pneumonia. Does anyone know what the main 2 top causes are of typical bacterial pneumonia? Any guesses to what you think the top most common causes of bacterial pneumonia is? Yep, so strep pneumonia is one of them. And oh, strep, yep, brilliant. Okay. Yep, brilliant, spot on both of you. So Streptococcus pneumonia is the most common, and then the second one is Haemophilus influenza. So those are just 2 to keep in mind. Great exam questions to get as well, just thrown in there. Cool, so case 2. So here we have a 24-year-old man who's present to the ED with sudden onset shortness of breath and right-sided chest pain after a minor road traffic accident. He is tachypneic, hypertensive, and has distended neck veins. So we've been given a chest x-ray, and what is the main finding that you can see on this chest x-ray? Brilliant, tension pneumothorax, yep. Yeah, right-sided. So as you correctly said, this is a right-sided tension pneumothorax, and this is something that we definitely don't want to miss. In terms of what signs we can see on the chest x-ray, can anyone point out some specific signs that would indicate a tension rather than a simple pneumothorax? Yep, yeah. Tracheal deviation, loss of lung markings, mediastinal shift. Yeah, really good answers, guys. So mediastinal shift to the opposite side of where the pneumothorax is. Depressed hemidiaphragm, and then you get compression of the contralateral lung, which we can see here. We've got that mediastinal shift moving towards the left, which is compressing that left lung. And yeah, you can see a lot of darkness, loss of that lung marking is quite black on that right-hand side. So what is your immediate management step now that we know this is a tension pneumothorax? What is the next thing immediately that you would want to do? Yeah, brilliant. Needle decompression, fourth intercostal. So this is quite an emergency situation. Usually, if this is based on clinical judgment, so if you think that someone has a tension pneumothorax, you would not wait for a chest x-ray. You do urgent needle decompression, and it's done by inserting a large bore cannula. ATLS guidelines from 2018 recommend the fourth or fifth intercostal space anterior to the mid-axillary line for adults. And then once you've got that in place, definitive management is a chest drain. So yeah, that is tension pneumothorax. Cool. So our next case, we have a 32-year-old man recently arrived from India who has presented with a 3-month history of cough, weight loss, and intermittent fevers. He reports occasional hemoptysis and night sweats. What is the main finding on this chest X-ray? Cavitating TB, right upper lobe. Yep. So, as you correctly said, David, we can see a large cavitating lesion with a slight air fluid level in the right upper zone, with some surrounding patchy consolidation, the sort of white area around that cavitating lesion. So, what are some of the risk factors for someone getting TB? Recent travel? Yep. Travel, immunosuppression. Yep, nice. Cool. So, yep, close contact with someone who has active TB, coming from areas of high TB prevalence, people who are immunocompromised, so people with HIV or people on immunosuppressant medications, malnutrition, homelessness, drug users, smokers, and alcoholics. So, what is the main management for active TB? There's a mnemonic for this as well, if anyone knows. Oh, I didn't know that they changed it to RIMP. Okay. What does the M stand for? I wasn't aware of that actually. I was just aware of ripe. Okay. So yeah, from what I'm aware, I just thought of ripe for so rifampicin, isoniazid, pyrazinamide, and ethambutol. Um, and you take the first two for 6 months, the bottom two for 2 months. But yeah, it'd be interesting to know what RIMP is. Okay, while we wait, I'm going to move on to the next case. So, case four, we have a 45-year-old woman who has presented with a 1 week history of fever, productive cough, and purulent sputum, also with pleuritic chest pain. On examination, breath sounds are reduced at the right lung base. What is the main finding on this chest X-ray? Oh, okay, moxifloxacin. Okay, that's good to know that that is also given in the regimen for TB. Yeah, right pleural effusion. So we've got this homogeneous opacification in the right lower zone. That costophrenic angle is obliterated, and you can also see that meniscus sign on the right hand side, all suggestive of, as you rightly said, David, a right-sided pleural effusion. So now that we know that this is a pleural effusion, what two other signs might you see on examination in a person with pleural effusion other than reduced breath sounds? So if you're doing like a respiratory exam, what other signs are you expecting to see in someone who has come in with a pleural effusion? Okay, so some signs that you might see on examination other than reduced breath sounds are dullness to percussion because of that fluid. So when you percuss, it'll be dull um, over that effusion area, over that right lower side on the back. You'll notice that there'll be some tracheal deviation if it's a really large pleural effusion. So when you're checking if the trachea is central, it won't be central, it'll be deviating away from that effusion. So say this was a really large right pleural effusion, it would be deviating to the left. So those are just two signs on examination to just keep an eye out. And just a little bit more about pleural effusions. So it's basically fluid collection in the pleural space and can be classed into exudative or transudative. Light's criteria, which is something you might have already heard of, is used to establish if it's an exudative effusion. And this is done using protein or LDH. So there's some criteria for this. So if the pleural fluid protein and the serum protein is greater than 0.5, then you'd put it as more exudative. If the fluid LDH or the serum LDH is greater than 0.6, or if the pleural fluid LDH is greater than 2/3 of the normal upper limit of the serum LDH. Cool, so we'll move on to case 5. So now we have a 66-year-old man who's presenting with a 3-month history of persistent cough, breathlessness, and mild hemoptysis. He has a 40-pack year smoking history. On examination, there is dullness to percussion and reduced breath sounds over the right upper zone. What are the main findings on this chest X-ray? Yep, so seeing some good answers in the chat. So we've got a very large round mass that is filling this upper zone of the right lung. There's also a slight pleural effusion on that right side because we've got that meniscus sign again. And based on that, based on that X-ray finding and the sort of history that we were given before, this is likely to be a lung cancer. And because obviously this is apical, this is at the top of the lung, it's something that we can think about like pancreas tumors maybe as well. Cool, so case 6. A 35-year-old woman presents with a long-standing history of productive cough and recurrent chest infections since childhood. She reports daily sputum production and occasional hemoptysis. On examination, she has coarse crackles at both lung bases and digital clubbing. What is the main finding on this CT chest? So I think the key things to take away from this history is that this is a long-standing history of a productive cough, recurrent chest infections, and that daily sputum production. And then the coarse crackles at both lung bases. Even if you're unable to interpret, say, the image based off that history, what kind of respiratory condition? Yeah, brilliant. Bronchiectasis is what we're thinking of based off that clinical history. And then in terms of the, dilated bronchi, so that's sort of what we can see on that CT. I'll go into a little bit more depth about how we know what we're looking at. So there's bronchial wall thickening and dilation. The bronchi are bigger than the accompanying artery, which is what gives it the signet ring appearance. So that's the classic sort of finding for bronchiectasis on a CT chest is the signet ring. So the dilated bronchus is the ring and the artery is the stone on the ring. So I've circled in red what the signet ring um, looks like. So the dilated bronchus is that ring, and then the stone on top, so that white bit that you see on top of that circle is the artery. So we've also got another finding on here, which is circled in blue. This is the peribronchial ground glass consolidation, and it's sort of this white consolidation that you can see next to the signet rings, and this usually indicates infection. So, yeah, that's how to identify bronchiectasis. You're looking for that signet ring sign, and it's basically that bronchial wall thickening and dilation. Bronchiectasis occurs because of damage to the airways, and some causes of this damage can be idiopathic, so there's no apparent cause. Pneumonia can cause it, whooping cough, TB, alpha-1 antitrypsin deficiency, connective tissue disorders, cystic fibrosis, and something called yellow nail syndrome. So now we're going to move on to the next case. So we've got a 72-year-old man with a history of hypertension and ischemic heart disease who's presented with increasing breathlessness over 3 days. He reports orthopnea and waking up at night short of breath. On examination, he has bilateral basal crackles, elevated JVP, and pitting ankle edema. What are the main findings in this chest X-ray? And there's quite a few findings, so just try to list one or two that you can see on there. Yeah, so we've got some good answers. Love the bat from Dr. Joshi. Um, so yeah, so we've got some really good answers in the chat. So we've got cardiomegaly, and that's when the cardiothoracic ratio is more than 50%. We've got some pulmonary edema, so something called curly B lines or septal lines. They're a sign of interstitial edema. Pulmonary edema can be split into interstitial or alveolar edema, and we've got both on this image. So the image in the top right that's circled in red, we've got these horizontal lines coming across, and this is basically called curly B lines, and they're a sign of interstitial edema. And then we've got air space shadowing, and that's the alveolar edema, and that's what the bat wing appearance is supposed to look like, and that's what is circled as number 3. And then we've got blunting of the costophrenic angle here on number 4, which is due to pleural effusions. So we will be moving on to the final case now. So we've got a 60-year-old woman with a history of breast cancer who's presented with progressive shortness of breath and chest discomfort over the past week. She reports feeling lightheaded when lying flat. On examination, she has a raised JVP, muffled heart sounds, and mild ankle swelling. What are the main findings that you can see in this chest X-ray? Yeah, brilliant. Water bottle sign for pericardial effusion. So we've got marked enlargement of this cardiac outline due to pericardial effusion, and it's called the water bottle sign. The fluid causes the pericardium to sag, which mimics an old-fashioned water bottle sitting on a bench. That's something that you can Google. I didn't even know what an old-fashioned water bottle looked like, but that's the sort of appearance that it gives. And generally, the effusion has accumulated over many weeks. So in patients with like a malignancy, and that pericardium has gradually stretched. It can be hard to distinguish between pericardial effusions and cardiomegaly, and comparing with previous chest x-rays can help with this. With cardiomegaly, you would expect a gradual progressive enlargement of the heart. But with pericardial effusions, the heart is normal on one chest x-ray and then a few weeks later can be very enlarged. If it happens quickly over a few weeks, it's unlikely to be cardiomegaly because that usually takes years to gradually enlarge. But in this case, it's happened quite quickly, and they've got a history of malignancy. So that's why we're looking at more of pericardial effusion rather than cardiomegaly. And it's important to note, because this is a AP X-ray on AP projection, the heart can look falsely enlarged, but in this case, even if you took into account the enlargement because of it being an AP rather than PA, the cardiac outline is still quite enlarged, which is why we can say it's probably pericardial effusion rather than cardiomegaly. And so we've done this chest x-ray for this person, but what is the best imaging modality to do for pericardial effusions? Yep, yep, great, Lucy, echo. So yeah, you'd want to do an echo with someone who's come in and you're thinking of pericardial effusion as a diagnostic imaging modality. Cool, so that was all the cases that I wanted to cover today. Here are some of my references. Thank you everyone for listening and contributing in the chat and making it interactive. And we also have a QR code. If you could please scan that and fill out the feedback form so we can improve for future sessions, that would be very helpful. We've also got a conference coming up at Leicester University on the 15th of February. It'll be really good. We've got some workshops, some talks from consultant radiologists, about things like AI in radiology and careers in radiology. So it'll be really good, really interactive. Overall, I think it'll be a really good day. So 15th February, keep a lookout on the social media page, Leicester Radiology Society.